The Vice Chancellor, University of Zimbabwe, Professor Nyagura, the Acting Permanent Secretary, Minister of Health and Child Care, Mr. Mangwanya, Dean, College of Health Sciences, Principal Officers of the University, the Principal Investigator for the Perfect Program, Professor Hakim, all protocol observed. Ladies and gentlemen, we are gathered here today to witness and celebrate the launch of a grant acquired by the college. The grant goes by the acronym PERFECT. It's a perfect grant, I guess, but it is for, in full, it is a grant for promoting excellence in research and faculty-enhanced career training. Then in short, we call it PERFECT. Without much ado, let me invite the Dean, College of Health Sciences, Professor Chidzonga, for some introductory remarks.
Vice Chancellor said, and representative Minister of Health, and of course all our esteemed partners, ladies and gentlemen. I would like to first of all thank the Vice Chancellor, our perfect Vice Chancellor, to come and help us celebrate this perfect achievement, which was the brainwork of one of our perfect investigators, Prof. Hakim. And I would like to thank the perfect audience for coming to witness this perfect occasion. As you will know, ladies and gentlemen, everything that is perfect has to start off on a perfect footing. And I can assure you, research is one of the things that gives us evidence for all our activities. Whatever you do without evidence is bound to fail. It reminds me when I was a little boy years back, there was this man from Mashonaland who visited Matabeleland in Bulawayo, to be specific. So as he was looking around, admiring the city, admiring the cars, he asked the question, said, whose beautiful car is that? And the gentleman, being in the belly speaker, said, Angazi. I said, oh, okay. And whose beautiful building is this? The man says, Angazi. I said, oh, okay. Went on and on, he was asking everything, and he was being told it's Angazi. And then he told himself, Mr. Angazi must be a very rich man. Sadly enough, he came across a funeral. He asked, which funeral is this? Mr. Angazi. And of course, he started wailing, thinking that Mr. Angazi is dead. So ladies and gentlemen, our trust and research is very important. It guides whatever we do. We are all gathered here to help, particularly young faculty, to be good researchers so that our practice, our teaching is evidence-based. And we have to thank Professor Hakim and his team for the efforts they put through for us to be awarded this perfect grant. And of course, it all stems from the Vice Chancellor. With his leadership and encouragement, we are where we are here. So ladies and gentlemen, without wasting more time, welcome and let's listen to the proceedings. Thank you very much.
At this juncture, ladies and gentlemen, let me call Professor Matenga to give us an overview of the MEP achievements. And I think as we go with the program, we'll come to appreciate the relationship between MEP and the grant which is being launched today, the program being launched today rather. Thank you.
Vice Chancellor, ladies and gentlemen, I'm going to talk a little bit about MEP, which is a program that has been running in the Faculty of Medicine for the last 5 years. Partnership Initiative. This was sponsored by the United States government through Fogarty and the NIH. The purpose of this particular initiative was to improve medical training in sub-Saharan Africa. So a number of schools, well, not the number, all schools in sub-Saharan Africa were invited to apply for a grant to improve medical education in their school. And 13 schools were awarded grants. And amongst these 13, the College of Health Sciences, University of Zimbabwe was one of them. And I need to mention that the college was the only one in Africa, in sub-Saharan Africa, which was awarded actually 3 grants, whereas all the others got 1 grant each. And I think again, this is because of the leadership that we had. Next slide, please. Let's just look at the situation in Zimbabwe before MEPI. Those of us who have been around will remember what was happening, particularly around 2008, 2009. Most of the members of faculty were actually leaving the country and going elsewhere. This had a bearing on the production in terms of graduation of medical students. So as you can see, this interesting slide, the actual graduates were going down. And at the same time, the number of lecturers were also getting fewer and fewer. So this is the situation that we were faced with before this MEPI grant. Let's the next one. Now, the grant itself, in terms of those 3 areas that I mentioned, involved a programmatic award which looked at training in the medical school in general, and then 2 specific linked awards, one which was called CRIS, which relates to cerebrovascular disease, training and research, and another one called IMES, which focused on improving mental health education. And subsequently, we got another award again, which looked at research, innovation, and management. Next slide, please. What was the goal of MEPI? Really, the goal of MEPI was to, if you remember the first slide that I showed you, the problems that we had. The goal of MEPI was to build capacity in terms of faculty, if we can get more teachers, and most importantly, retention, because there's no purpose in training people, becoming members of faculty only to leave and go for greener pastures. And these members of faculty were supposed to be involved in relevant research, which is very important for any faculty members. Next slide, please. Now, let's go through the transformative change that occurred after we were awarded this grant. Next. We applied a few strategies. First of all, we targeted the best postgraduates that we could get hold of. And we selected a number of them for particular programs. And some of them were asked to establish disease registers. Now, disease registers, basically, that's where a registrar or a young doctor keeps collecting all patients with a particular disease. The purpose of this is that if you do that, then if you want to do research, you have actually got the subjects there. You are creating an environment for research. Then we, of course, were involved in local skills training and research training. Now, to also improve the training, we send out some of these fellows or students on attachment to our partners, abroad. We'll mention this, we'll come to this a little later. And then we had a program called Mentor and Scholars Program, where if you had a scholar, you are attached to a particular mentor, and these two would work together for the purpose of producing credible research. Next slide. Now, one of the things that also we did as amongst the strategies, I think this would entertain, this would, the Vice Chancellor would love this because I know this is his area of interest. That for a change within the faculty, we decided to actually carry out some strategies which are shown there to modernize training and teaching by using IT. And there were a number of things that were done, which included infrastructure upgrading, data center with all sorts of data which the students could get access to, Wi-Fi, and for a change, I think some of you may have been seeing students working on computers in the corridors, in the hospital. This was because of this particular program that we're doing. And then the students themselves were trained how to actually use IT in terms of accessing data, finding evidence. If you can just quickly, right, let's go through. Right. The other thing that we did, and this was really, because we didn't have enough lecturers on the ground, we were short of lecturers. So we initiated a program called Visiting Professors. Now these were coming from our partners abroad, coming in to help with the teaching. And they brought in also teaching materials, which they actually left behind. Next slide. Now, so with those strategies, what actually happened? I'm now giving you the results of the MEPI exercise. I'm going to go through the numbers, recruitment and graduation, establishment of subspecialty services, impact on academic activities, and impact on medical care delivery. These are things which changed because of this particular program. Next slide. Now, in terms of numbers, this particular program, we actually trained 82 fellows who went through the various programs that formed part of the MEPI program. And out of these 82 fellows, 10 of them have already joined faculty. And in fact, the numbers will increase because there are some who we watching at the moment and persuading them to actually join faculty, and we are quite sure that they are going to join faculty. So the number will actually increase. So we are in the process of generating our own faculty. Next slide. Now, recruitment. Look at this slide, what was happening. I'm just using medicine as a case here to show you. Around 2010, there was one time when, in fact, we didn't have any students doing medicine in the Department of Medicine. And I remember we used to go around. If we saw any SHO who was walking around, we would actually grab him and persuade him to join the program. And as soon as MEPI started, the numbers slowly started creeping up. The blue line is the people who are now applying to join MED, and the red line is those accepted. And I think we don't need to be real rocket scientists to see that, in fact, there was a change which occurred. Now, you might think it was medicine alone. Let's look at psychiatry. Psychiatry was training in 2010 just one person, one student. And after MEPI, the numbers increased, and now they are training an average of 4. And that's quite a large number if you consider where we were before. Next slide, please. Now, psychiatry again is an interesting branch. In 2010, there was only one lecturer, the whole department. And look at what has happened. Slowly, the numbers have gone up, and now they have 5. And 1 or 2 of these lecturers are actually from this program. The others got attracted back because things now, the atmosphere is now more academic, research, and people now are getting excited about what is going on in the faculty. Next one. Now, let's look at combined medicine, pediatrics, and psychiatry. Student intake, again, going up, as you can see. Next one. Graduation for the combined, again, departments, going up again. Okay, next one. Now, let's now look at the impact on clinical practice. One of the interesting things is that most of you will understand when we talk about tertiary hospital or a teaching hospital, it only becomes a tertiary hospital or a teaching hospital because there is a lot of advanced procedures which are being done at the hospital. So the patient in Karoi or in Guwe will be referred here because more can be done in this hospital than at Guwe. Before 2010, we no longer had any sub-specialist clinics at all. There was nothing. Now look at what has happened. Now we've got a child psychiatry clinic, which we never used to have. We've got a neuro and stroke clinic, which didn't exist. Cardiac clinic, endocrine clinic, respiratory clinic. Let's show them the pictures. This is a good one. These are psychiatrists, I think, trying to figure out what this person is thinking about. That's called an EEG clinic. We were no longer doing this kind of thing. And now this is available. Next slide, please. And this is particularly an interesting slide. I think I see the clinical director of the hospital is smiling because he recognized this lady who is the principal nursing officer who was attending a stroke management training workshop within the hospital. So all the nurses came down to be trained on how to manage strokes. We have got actually one of our fellows who's going to talk about this a little bit later on. Next slide. Now, pacemaker. A pacemaker is a little gadget, it's a little battery. They are getting smaller and smaller. They used to be very big. It's that small. Which if a person's heart slows down for some reason, you can actually implant that pacemaker in the person and control the speed of the heartbeat. And it's a very, very effective treatment, which if you did it in an old Ambuya from the village who couldn't even go to the well to fetch some water or go to the field, you put a pacemaker, 2 days later they are actually up and running about and doing all sorts of things. Now, this, we had stopped doing this some years ago. In fact, I don't know, Professor Akimi, if you can remember the last pacemaker that we ever attempted to actually implant. I can't remember myself. But now this is available in this hospital. Now we can implant pacemakers. And some of, these two fellows here are visiting professors who are actually teaching our own fellows within the MEPI program. And those fellows, I don't know if Dr. Fana is here, they're not here. They are now doing it on their own. They don't need any help from anybody. So in fact, we can now plant pacemakers. So now we are a referral hospital. Next slide. These two characters here are actually doing what is called bronchoscopy. Now, bronchoscopy is when you look down the lungs. If somebody is coughing and you think they've got something in the lung, you actually pass one of those tubes which has got a light at the end, and they look and try to figure out what is going on. And these two fellows went to Denver for a few weeks, came back, and the visiting professors followed them and taught them how to do bronchoscopy. Now they are actually doing it on their own. So again, we are now a referral hospital, so we can do procedures which can be done in Karoi or elsewhere. Next slide, please. Now, the stroke unit, I'm not going to talk about it because one of the fellows is here and he's going to describe what happened. Except to say that this was quite interesting, because this was an initiative started by the fellows themselves. They went training on how to look after stroke patients, and came and set up this thing. And this has worked so well that even the ministry got excited, and as you can see, the Minister of Health is there, his deputy in that gold tie, and I think that gentleman might be the WHO country rep. And they got so interested in this that they had to come into the hospital and actually see this initiative which was started by the MEPI fellows. Next slide, please. So that's the impact on treatment and management of patients. What about the impact on the college itself? Well, there were a number of things that actually took place. We had, I'm sorry to say, I can't remember the last time that we ever reviewed the curriculum until this happened. And as you can see, we have had a review, curriculum review of HIV, TB, malaria, college-wide curriculum review in 2012 to actually look at the curriculum. What are we teaching these students and how are we teaching them? And then this program came on the scene where now faculty actually do a diploma in health education. Now, I always tell people this, that most of us, me in particular, I got recruited to teach, not because I was trained as a teacher, but probably I had a loud voice or something, and they said, come and join, and that was all. No idea about it, what adult education is all about, and how do you train teachers. And now we can actually do it. And there was a lot of faculty development workshops, lots of them. In fact, I think the secretary who put 8 there is wrong. I'm sure it's more than that, because I remember attending so many of them. And this is a purpose to improve the quality of the teachers in the faculty. How do you teach? How do you assess the student, etc. Next slide, please. And the building which you are in now is that one. This came up because of MEPI and SACO. These are research projects which were going on, grants, where in fact the faculty was able to put up some money to put up this building as a research support center. So anybody who is interested in research, who has got a question, needs advice, is able to come here and actually be advised. This is a development for the faculty. This one here is the Department of Health Professions Education, which was opened by Vice Chancellors some time back, I can't remember when that was, and where in fact, again, under the care of Dr. Zimbabwe, there he is in the corner there, and he looks after this particular place. So members of faculty go there and learn on all these skills, how to teach, etc. So these are the kind of developments that have occurred. Next slide. So how do we measure that we are doing better than we used to do? One of the things is to look at grant applications. You look at the college and you say how many grants have been applied for. And as you can see, again starting from 2011, slowly going up, and sadly in 2014 this is shot up. There's lots of people now applying for grants, research grants. And this one, the orange one, those actually were granted one. Okay? Am I right? No. You awarded this funny color there, and those are pending. So again, you can see that there's now activity within the college. Next slide. We look elsewhere. What about presentation, scientific presentation at international meetings, local and abroad? There's been quite a lot of publications and presentations, etc., which have been going on. And I must say that I'm proud to say that during one of the annual research day meeting, the college, 3 of the best presenters were actually from Greece. I wasn't there, so there was no chicanery or anything in terms of selecting these students. Next. Now, Jeffert, for a long time, was the only lecturer in physiology. He was actually the only lecturer in physiology. And with this program, we selected a number of clever students, and they took off 1 year to do BSc intercalated in physiology, BSc physiology. And this actually is one of the students now teaching the part 2s. So now Jeffert is very happy. He's got a couple of people to help him. So these are the kind of developments that have occurred with an impact on the college. Next slide, please. Now, obviously, the issue everybody will talk about is to say, what about sustainability? Now this MEPI grant is ended. Where are we going? Do we pack our bags and retire and go home and forget about it? Or is there something that can be done? Now, we think, next slide, we think that, next one again, right, there's a number of initiatives that maybe those that have undergone the initial MEPI training need more advanced research training. Now we think that this would be very, very useful, because then you train them to become independent researchers. And at the same time, if you just click it on, I don't know what is happening, sorry about this. If you do that, you are creating teachers who will come back and teach in the college, and at the same time continue again with the program in terms of research. Now, all this would not have been possible if we didn't have partners who assisted us. Next slide. And these were the partners. So we have the logo of the University of Zimbabwe, Stanford University, King's College, Colorado, Cape Town, and Institute of the National Institutes of Health, etc. These participated. Next one. Now, it's not possible also unless you have good leadership. And we had wonderful leadership. I remember every time that the evaluators came, almost every year, to look at what we were doing. On the first day, they would be called to Professor Nyamura's offices, and Professor Nyamura would have a chat with them. We would also be sitting by, and most of the chat would be encouragement. Please go on, and what else can you do? If there is anything that I can do, I will help. And that is the kind of leadership that we had, which made it possible for this to occur. Anyway, of course, the dean and the faculty, Professor Chitonga, they made it, made us feel that this program was actually owned by the faculty, and it was a faculty project, and that made it also again easy to work. And then of course the Ministry of Higher Health and Higher Education, and in fact Ministry of Higher Education actually contributed about $250,000 one time. They just suddenly said, we like the program that is going on, here is some bit of money and use it as you wish. And I remember the money part of that I remember very well. We actually bought books for NAST medical school. So this is expansion. This is some of the effect. And of course the MEPI committee members, the scholars themselves and so forth, and the secretariat. Of course, next slide. There was a leader. Now, if you quickly read this, This came out as a news bulletin on the, I can't remember what the date was, in January. I always feel that if Professor Akim around during the time of slavery, he would have been a slave driver. This gentleman, working with him, is a workaholic. We, most of the time, would leave the offices very late in the evening because there's something that is thinking of. And we have to do this, we have got to do that and the other. And I truly believe that the success of MEPI Zimbabwe has to be attributed to Professor Akim. And even the University College of London recognized the scientific contribution that he has made in this medical school over the last 20 years, and has now awarded him Doctor of Science in Medicine. So we think that I'm not trying to beat my own chest, but I think MEPI has done extremely well. Tatiana.
Thank you, Professor Matenga, for that informative overview of the MEPI grant, particularly its achievement and impact on the University of Zimbabwe Biological Sciences Ministry of Health and the like. Maybe to have further evidence for the achievements of MEPI, we will now proceed and have presentations by two scholars who have been under the MEPI program. And for that, let me start by calling Dr. Matarose, and then while he presents, maybe Dr. Wafa to prepare the next presentation.
Good evening. Despite I'm honored to be called when I was invited to come and present, I thought I was going to pass out, but I want to acknowledge the Vice Chancellor, all the respected guests who are here, the senior lecturers, and all the members of faculty. So today I'll take you through the journey that I traveled when I was doing my MA program. So I started with the presentation, establishment of the stroke unit in the local resource setting, Harare, Zimbabwe. This presentation, I would want to highlight at the onset that to one of the best young scientific presentation, Zima 2015, also the presentation was also accepted at the CUGH, which is Consortium of University of Global Health in Washington, D.C. So we are quite happy to be associated with this presentation as well, in our own capacity. So what drove us to the establishment of the stroke unit was the background that we realized that stroke was the second commonest cause of death in the world. And important to note that in 2012, when I was doing my second year and I was actually asked to come up with a citation topic, one of the things that struck us was that the stroke patients were being managed in the general medical ward. So there was no stroke unit at that time. But however, contrary to what we believed at that time, that patients, there was evidence to suggest that patients who were receiving care in organized units were doing much better. That was the first point. We also noted, just down south, that patients who were actually being taken care of in the stroke unit had actually a better outcome in terms of mortality. You can actually see that South Africa recorded 33% reduction, so from 33 to 60%. So I was fortunate enough to be part and parcel of being a Chris fellow. And Chris Grant is, Prof. Matenga, as I just highlighted, is part and parcel of the MEPI projects. So what were the issues that we were looking at the time? So I had to come up with a dissertation topic. So the basis of how we then established the stroke unit was we had to come up with the baseline data. And baseline data had to come up from somewhere. So we had to establish a stroke registry. And then the dissertation that we then chose was the mortality and short-term functional outcomes of stroke patients who were admitted at Paranyada hospitals. I would want to highlight at this moment in time that stroke by definition is what we then see as the weakness, as the inability to speak when the brain is starved of blood, whether because there is a blockage in the blood vessel or whether there is a resting vessel. But important to note is that in this study, we had to come up with the baseline data to look at the magnitude of the problem. So what were the issues that we then came up with? We then noted that we had to start from somewhere. So the birth of the stroke registry was on the 1st of November 2012 and it stretched all the way 31st of December. Important is that clinical stroke, clinical meaning that the diagnosis of stroke was made on the clinical basis by a standard definition of stroke, the WHO standard definition of stroke, because most of our patients could not afford CT scans. Important to note in this data, we are going to highlight that around 66% of our patients managed to get CT scans to confirm the stroke. The last part of the slide highlights that we only took 251 patients, and these were the patients who were presented for the first time with a clinical diagnosis of a stroke. And this was important because it's really sort of we're looking at outcomes, and that was going to be important. So what were the key results that we noted? We noted that from the 251 patients, 62 patients were lost in the first 7 days of their admission. And this came up to 24.7%. So 24.7% is, so the slides are getting out. Okay, let's go. So we then say, on those patients, the 62 that we lost, what were the causes of death? Because we definitely have to look at so that we can mitigate the problem. Because we noted that the burden of disease was there, 251 in 1 year. Then we noted on those 251 that we lost 62. And the 62, the idea now was to try to find things that we can correct and then sort of try to solve those things so that we can actually have better outcomes in terms of stroke management. So we note from this slide that you realize that the highest percentage was those patients who had presented with pneumonia. And by definition, in terms of pneumonia, this patient had aspiration pneumonia. Basically, these patients develop pneumonia after they've been forced to feed. Sometimes people care for those patients who had stroke, and at home people try to feed. Naturally, it's the tendency of loving, isn't it? But important to note that these patients, we lost them. So the greatest percentage of patients had aspiration pneumonia. We had other patients as well who had worsening stroke symptoms and elevated blood sugar, as well as patients who had post-stroke sugars. I'll take you to the slide and just note that the odds of dying, meaning that you were more likely to die if you are presented with a stroke and aspiration pneumonia. The highest rate of death was actually with worsening stroke symptoms, but we were looking at things that we can control. So aspiration pneumonia was one of the things that we thought that was easy to control in terms of managing the patients. So, having noted this baseline data, the CRIS scholars, myself and Dr. Ngwengo, who's another CRIS scholar, we had to go to our partners, MET partners and UCT to actually go and witness and establish stroke units, because we had understood the burden of disease, we had understood indications of what we want to do in terms of what we want to address, but the solution was going to come from a stroke unit perspective. So through the CRIS grant, we were allowed to go and visit our MEP partners, and there we identified the treatment gaps that we are now recognizing in terms of our patients. And this gave us to come and establish our own adopted stroke protocol. This stroke protocol, I would try to dwell much on this. It looks mainly on the issues that we had looked in the previous study. And important to note is that the swallow evaluation was one of the key things that we wanted to actually look at in terms of management of the patients, because basically most of our patients with lost control, swallow, issues of feeding when they actually had a stroke. We also looked at issues that the patients had to be hydrated, temperature control, blood and bowel issues, and this was very, very important. And these were the issues that we're now training. When you saw the slide that Professor Matenga showed, where the PNO or the principal nursing officer was being trained in stroke management, these were the issues. We're thinking that we would address these issues, and this didn't cost us money to address these issues, to actually establish a good care in terms of our patients. So we then negotiated. I'm quite happy that the CEO is here and the clinical director, and we negotiated. It was a number of meetings, and again we were then awarded 8 dedicated beds in a stroke unit. So by definition, a stroke unit is just a geographical place which is well defined where you take care of stroke patients. So important to note, with these 8 beds, we have 2 cubicles in Ward C7, and this is just a dedicated place where the admission there is going to be on stroke patients only. We had promised the CEO that would, if the beds are free, we can always admit medical patients as a way of managing the politics. Yeah. But however, we then went on to train dedicated physicians and dedicated nurses. And then we opened the stroke unit in November 2013. And that was the stroke unit. And I'm quite happy that Professor Matenga was also there to witness the first patient being admitted. So what was the experience then? I would sort of take you to a short summary to say we did manage to identify the problem, the magnitude of it, and we then found a solution. And the stroke unit was then established. So the question now is, how then do we measure the impact of the stroke unit? So we'll take you through the experience in a few slides. So 440 patients have been admitted from the time that the stroke unit has been established. And the interim data that we have is up to May 2015. We're still yet to provide you the current interim data. And important to note is that there was quite significant reduction in terms of the first 7 days in terms of mortality in those patients. We now record a mortality of 7.3% versus 24.7% as we've seen in the old data that we provided in 2012. And the odds ratio there was 0.6. So definitely you can see that the magnitude of reduction of the problem is about 75%. So your odds of survival is quite high, especially when you're in a stroke unit when you look at this. Important to highlight that in the stroke unit, we do admit both patients with old strokes and those with new strokes. And in 1 month's time, when you look at the 1 month analysis in terms of the mortality in 1 month, some people can actually argue to say, no, but 7 days is quite a short time. Let's look at much longer time. Again, it's 10.8% in terms of mortality rate. Still quite significant in terms of benefit if you look at it in the long term. And important to highlight is that we didn't ask for money or ask for any budget. What we asked was for the beds in the geographical space. And the next thing was to train. So basically, when you look at this intervention, it's a low resource setting intervention with quite a magnitude in terms of your outcomes and the benefits that you actually get. So, okay, that's fine. So, this stroke unit, we are quite happy that the clinical diagnosis of a stroke is good enough for you to get into the stroke unit. So CT scan issues becomes less of an issue, but however, it becomes very important to determine whether someone has bled in the brain or someone has an infarct. But the clinical diagnosis itself warrants you to be treated in the stroke unit. And the results are quite so marvelous so far, and I'm quite proud to be associated with that Prof. Matenga. And thank you again to have allowed us to have the opportunity to take care of stroke issues. So what are the issues? The interim data does suggest that this is the way to go in terms of stroke care. And it actually helps us that to note that there is low-cost implementation, so we can actually do it in any hospital. It becomes quite a challenge to the policymaker that we can actually even go an extra mile to shift task the roles, to say we can even establish a stroke unit where a nurse can actually take care of that. And we are still yet to do those studies to see whether the outcomes will be different. Because in other places where they are remote, where there's no specialist service, I think that the impact can still be good enough to look at that. And I'm quite happy that the Ministry of Health has adopted the stroke unit as the standard of care of strokes in Zimbabwe. And future research is still yet to be looked at in terms of the long-term impact, but so far we are quite happy with what we have. So this is another view. Prof. Matenga, you took it from the other side, I'm taking it from the front. It's another view of the same again, the minister touring the stroke unit. So thank you so much. This is the presentation that I thought I would share with you, with the journey that I traveled through as a Chris Fellow. And I'm quite proud that I'm now a qualified specialist, and I'm still quite happy to be associated with the hospital as well as the university. Thank you so much.
All right, thank you, Dr. Matamse, for your presentation. But what I'm not sure of is if you are going to go back to the hospital and negotiate for more space or anything, whether that will be granted or not. Anyway, let me call upon Dr. Wafa to share with us her presentation as a MEPI fellow.
Good evening, everyone. I'm Chido Wafa. Good evening to the Vice Chancellor and to all the respected guests. I was an IMES Fellow, which was part of the MEPI programs, which was the Improving Mental Health Education and Research in Zimbabwe grant. I did this project as part of my Master's in Medicine dissertation, and I was supervised by Dr. Mangesi and Dr. Madongiro, who are lecturers in the department, and I acknowledge them in this presentation. I've previously presented this data at the Zimbabwe College of Psychiatry CME Days, and also an addictions masterclass that was arranged by IMES towards the end of last year. So I looked at substance abuse in our admitted psychiatric patients. Why? Because alcohol and psychoactive substance use is becoming a significant problem worldwide. What is a substance? Maybe we need to just define that. It's anything that you take, any substance that's taken that then changes or alters the mental state. So alcohol is a psychoactive substance. The data, however, in Zimbabwe is limited. But I looked through some of the WHO information, and I found that back in 2004, they had some data that 3% of our adult population, those aged older than 15, had a drug or alcohol use disorder. But this is like a once-off figure. And then they also had some information about some of the consequences that are happening due to substance use or abuse in Zimbabwe, and that quite a significant number of people are dying from alcohol-related road traffic accidents, and also substance-related injuries due to interpersonal violence and complications. Then I spoke to the police just to get an idea of what was the sort of substances that are on the market in Zimbabwe. And in 2012, the drug unit of the Criminal Investigations Department found that of the drug-related crimes, 75% were connected to cannabis, and 56% were connected to illegal cough mixtures, particularly one called Bronchoscopy, which I'm sure people have heard about. Then I went to look at our surveillance data, because our hospitals are keeping information on diagnoses. I looked first at outpatient data. So patients come in as outpatients, and then their diagnosis is noted in the register, in the attendance register. If you look at the red line, that's substance-related diagnoses. And then the blue line is alcohol-related diagnosis. And if you can ignore the fluctuations throughout the months and look at the linear, which is in gray, there is a trend. The trend is going up in terms of the number of patients we're seeing in outpatients who have substance use problems. Then looking at admissions, again at Parenia as well, I looked at the records from 2012 to 2014, and it looked like 37% of our admissions were related to either some substance or alcohol, which is quite a big burden. Then I went down south to see if there was any difference in terms of geography. Gomahuri is a long-stay facility that's in the southern region of Zimbabwe, Masvingo, close to Masvingo. And they also had some interesting information that a quarter of their admissions were also substance-related. And furthermore, they said of that schizophrenia portion, 64%, they said more than 80% of those patients would also admit to some form of substance use as well. So their burden is also high. So the justification for the study then came that the surveillance data is saying there's a problem. It may be increasing. The current lack of dedicated addiction treatment centers in the country means that people with substance use problems will be seen in psychiatric units, which will be tertiary psychiatric units usually. And then the last published data on this particular topic, which is prevalence of substance use with admitted psychiatric patients, had been done by Professor Achuda and Professor Sebit in 1994. And from that information from the police, it seems things may have changed since then. So my research question then became, what is the prevalence and factors associated with psychoactive substance use among patients admitted to tertiary psychiatric units in Zimbabwe? And the main objective was to assess prevalence and factors associated with the psychoactive substance use in admitted patients. The specific objective was prevalence, and how to look at that, I was looking at patient self-report, so just asking the patient through administered questionnaires, looking at a qualitative urine screen for drugs, and then a review of the patient's file or case notes, and then to also look at the factors associated with that. And the study population was patients who were being admitted to Harare Hospital Psychiatric Unit and Arenyatwa Annex Psychiatric Unit. The sampling frame I used was the admissions register and also the nominal register, because after a pilot, we actually realized that admission register wasn't as complete as we would have liked, but the nominal register was much better. The inclusion criteria, of course, included informed consent for those above 18, or assent and informed consent from a caregiver for those below 18. The sample size was 382. The sampling procedure was that patients would be admitted by doctors other than myself for that duration. So there were interns or SHOs who would admit the patients. I would then follow later on in the day or the next day, and then attempt to get informed consent, which is a challenge, if you can imagine, in a psychiatric unit. Sometimes I would get informed consent that day, sometimes I would get it a few days later, but I would attempt to get informed consent, and then once I have that, I would administer the interviews and then do a urine screen and then look through the case notes. The administered questionnaires included a socio-demographic questionnaire that we designed for the study. The WHO audit is WHO 2, which is the alcohol use disorder identification test, which is used to screen for alcohol use disorders. So someone can use alcohol but not have a disorder, but then once the use has passed a certain limit, you can actually screen and see that they've got alcohol use disorders. And then the DUS-10 is a drug abuse screening test, which is modified from the Michigan alcohol screening test, but this is for drugs other than alcohol. So anything else that's not alcohol. And then I looked at the case files, looking for the primary diagnosis, and also looking at the substance use history, the quality of the substance use history, and then did the urine transfer. So looking at results, the socio-demographic data, the mean age was around 31. Most of the patients were male, residing in high-density areas, and of black race. And then this was the patient self-report. So having asked the patient which substances, the list of substances they could respond to, among the legal substances, the majority of patients admitted to using beer. This was reduced in the last 12 months. But then what's of note is in the red, which is what we need to worry about. The illicit alcohols. These are alcohols that are not licensed for use in this country. They're being smuggled into the country and being sold in the black market. Before, there used to be home brews, but actually I had one of those home brews as an option. The majority of patients would actually pick those imported illegal alcohols, which include things like double punch, like Z, those illegal, and they're usually high potency, and we're not really sure what's in them besides the alcohol. So 24% of our patients, of the sample, admitted to having used that sort of alcohol in the last 12 months, and 39% admitted to cannabis use, 22% to the cough syrups, the Bronchoscopy. Then the others were not very significant, particularly the hard drugs, which I guess is some sort of good news. Heroin, amphetamines, cocaine, patients didn't admit to that. Looking at the WHO audit, so we're now screening for use disorders, not just use. So 27% admitted to harmful hazardous alcohol use, which is the WHO score of 8 to 21. Above 21, it becomes dependent. So 12% of our sample actually had alcohol dependence. And then looking at drug use, apart from alcohol, 38% had harmful dependent drug use. Looking at the urine screen, what's of note there is that cannabis, 54% of the patients who consented to the urine screen actually tested positive for cannabis. The benzodiazepines picked up high, but there could have been a confounder there in that we do give benzodiazepines on admission to calm patients down. Then looking at the case notes, again, the substance-related admissions is quite high. So these are the diagnosis in the case notes. Substance-related was 40%, way more than all the other diagnoses. So the burden there on the psychiatric unit is quite high. Looking at factors now associated with use of alcohol, the factors that were statistically significant included being aged 40 to 49. So that means that you're almost twice as likely to use alcohol if you're in that age range than in the other age ranges. Which is surprising because you think they were younger, but maybe they have more money by the time you get to 40. And then another surprise was the female. You were 5 times more likely to use alcohol if you're female instead of male. But then, of course, we had to look at the number of females in the sample was actually just 90. So that could have affected that result. And then the primary diagnosis of depression or bipolar or HIV-related psychosis was also associated with use of alcohol. Then use of cannabis was associated now with a younger age, being aged 20 to 29. So you were 4 times more likely to use cannabis if you were in that age group than in the others. And being male, but again, the confidence interval was quite wide. Then being single and having a substance-related primary diagnosis. Then the cough syrup abuse, again, the younger males, 20 to 29, and the high school education, having high school as the highest level of education. Then the high-density neighborhoods. So these were patients who were staying in high-density neighborhoods. That means you were almost twice as likely to use cough syrups if you were staying in a high-density neighborhood compared to the other neighborhoods. That's significant. So in conclusion, comparing with Prof. Achuda and Prof. Sebit's study, there seems to have been an increase in prevalence of psychoactive substance use among patients admitted to our units. And there's emergence of new psychoactive substances, those illicit alcohols I explained, and the cough syrups. And the use of cough syrups, as mentioned, is associated with younger males residing in high-density neighborhoods and substance-related diagnoses. So what to do? One is the decongestion of the acute psychiatric ward. Because 40% of the ward is due to substances. We may need a subacute unit that will look just into addictions. And I think Harare Hospital has started to look into renovating and maybe setting up something that will be subacute that would work for us. And then the routine use of urine screening in the psychiatric units, I think the department is looking into that. Because just to note there, the tests were not very expensive. I think it's $3 for one test. And I thank Ines for helping us source those for this study. And then training in comprehensive record keeping, because I think in looking at the notes, we were found a bit wanting. And interventions would need to target young males in high-density neighborhoods. And further research in terms of auditing our record keeping, in terms of interventions, would be in order. Thank you.
Thank you, Dr. Wafa, for that informative presentation. At least members now know what is the substance and which substances are psychoactive. Right, when we started, we said we were gathered here for the launch of the Perfect grant, and I think what we've gone through is the background to prepare for the presentation by Professor Hakim on the Perfect program. May I invite Professor Kim for his presentation.
Thank you, Director of Ceremonies. Let me recognize the presence of the Vice Chancellor and welcome him as our guest of honor. Let me recognize Mr. Mangwanya, the representative of the Permanent Secretary, Ministry of Health and Child Care. Recognize Mr. Zigora, the CEO of Marinyata Hospital, and our host in many ways, including hosting Nectar and now hosting Perfect. Let me also recognize the presence of esteemed partners, colleagues, and friends, including Johnston there from Colorado, scholars, ladies and gentlemen. Now, sometime in 2014, we learned of a request for applications, an RFA, for applications to get awards to train junior faculty. So, like we have now, has become a tradition, we go to the dean and we ask him to give us permission to call for a meeting of opinion leaders, and we unpack the RFA and ask members of the college if they thought this was a worthwhile endeavor. We did that for Nectar, Chris, and Imhez, and we did it again for Perfect, and I guess it was 16th of October 2014, and we got a resounding yes, go ahead and put together that application. This is indeed appropriate for the college. So a group got together to really focus on writing the application. Professor Matenga there, Professor Chipato, Professor Mbizo, Mr. Chigono, and Mr. Magwali, and we were assisted by Nectar administrators, mainly Toko and Antony. So we had only 8 weeks to put together what was clearly a fairly complicated application. So as Professor Matenga stated, we burnt the midnight oil. So we worked fairly hard, and we were leaving every day at 7:30 p.m. But people were pleased because, the application was coming together very nicely. When time was insufficient to really dot the I's and cross the T's, we began to come on Saturdays and on Sundays. And a few people began to grumble. And especially those who don't go to church were grumbling most. Anyway, we got the grant. And in fact, our grant was judged to be extremely strong. So we were contacted by NIH to try and put together a few more supplementary requests, which we did. And some of you who knew that we were planning to train 15 junior academics learned later on that we intend to train 30. So we were successful there. We then got the funding released in September, and I got together this gang of 5, and I said, well, let's get working. And Professor Matenga said, wait. I think we must go back to the college and inform them about what we did in MEPI, and also tell them what we intend to do in Perfect. I said, wise man. And this is why we're here today, and we'd like to thank Matenga for really pushing us to come together and have this occasion and share some of the successes and some of the intentions that we have. Right. Perfect is an award, and basically it's an award to train junior academics. We call them junior faculty, that's how the US tends to call them. And the NIH, through the Fogart International Center, put together 35.5 million and funded 11 sub-Saharan African institutions. And this is basically really the successor to MEPI. And the purpose is really quite focused, unlike MEPI, which had a very broad mandate. And this was to train junior faculty at African academic institutions to pursue research careers. And the awards were in 8 countries. And some of you may recall that the MEPI award was in 12 countries and 13 institutions, South Africa having been awarded 2. But this particular award was just to 8 countries. And these are the countries here, and I've put countries which have got more than 1 award in different colors. There are 2 in Uganda and 3 in Nigeria. Just a few statistics to sort of press home the importance of really focusing on improving research capacity in sub-Saharan Africa. The World Bank put out these statistics, and in the US, for every 1 million people, there are 4,650 biomedical researchers. In sub-Saharan Africa, excluding South Africa, there are a whole 56 researchers per million population. And sub-Saharan Africa produces less than 1% of the biomedical publications that are available in the world journals and other publications. And if you look at articles, biomedical articles produced, an African author is mentioned in only 2.3% of these. So really, I think perfect. Promoting excellence in research and faculty-enhanced career training is most appropriate. This is to train a critical mass of junior faculty to become the next generation of researchers at the UZ College of Health Sciences when Professor Hakim and Professor Matenga are not there to do any research anymore. So we have a novice, and we would like that novice to become an expert. So how do we achieve that transformation? How does Perfect achieve that transformation? We want to produce competent, independent researchers. You should be able to look at a research announcement, determine if it's appropriate for you or your institution, sit down, get together colleagues, and put together an application which is competitive. So capable of successfully competing for funding. You cannot do research without dollars. So it's extremely critical to keep that in mind, that you must compete for dollars. And I always tell people that, you know, the NIH, the MRC UK, the Wellcome Trust, Chinese funding agencies, Scandinavian agencies, those funds, even though they are named, you know, by the countries that award them, they are really available for anybody in the world because disease and ailments are international. Look at what happened to Ebola. Ebola killed so many people in Sierra Leone, Liberia, and Guinea, but it became so important to Europe and to the US. See what is happening to Zika. You know, so it's so important to think of any of these awards as being answering an international problem, even if the problem occurs just in your backyard. And we want to produce people who are able to collaborate internationally. It's critical. You can't, you know, sit in your office and expect to do good research, or in your own hospital and do good research. You must collaborate with others. So we had to choose scientific areas that would focus our research on. And we chose respiratory diseases, women's health, cardiovascular diseases, HIV, AIDS, mental health, dental and craniofacial disorders, and hematology. The initial application was for women's health, cardiovascular diseases, HIV, AIDS, and mental health. So when we were asked to put a request for supplementary funding, we strategized and went to a specific institute, the Institute of Heart, Lung, Blood, and applied for respiratory disease funding, hematology funding, and knowing that our dean is a dentist, we thought that was strategic. Now, even though the focus is in very specific areas, you know that our college has several disciplines, and the intention is really to work across all these disciplines. So it's really up to an individual in whichever department, whichever discipline, to determine how they fit into that big scheme of things. So these are really guiding numbers. They could change, we are free to change that. So in HIV/AIDS, we think we want to train 4, cardiovascular diseases 7, women's health 4, mental health 5, respiratory disorders 2, hematology 2, dental and craniofacial 6, again for reasons which are given above. So our intention is to train 30 junior academics during the 5 years. Now that might appear to be a modest number, but what I'll show you, the intensity of the training will impress upon you the fact that it's quite labor intensive. Now, I will not go through each of the subtopics that we put down in the application. I'll just mention a few highlights. So in HIV/AIDS, the big headings of prevention, treatment and care, basic science, and the comorbidities, TB, crypto, and so on. And then the important groups like adolescents and orphans, and of course the importance of implementation science, like what young Dr. Mataruse there showed us, and what Dr. Wofa also showed us. In neurology, I think there is nothing better than success, and we think we've been successful with stroke, and we intend to really pursue that further. And strokes goes hand in glove with hypertension. Epilepsy, and in cardiology, in fact, if we had had, a full day's seminar, we would have brought in other scholars who would have really shown you the breadth and depth of research that the scholars did under MEPI. And there's some really excellent work that has been done in heart disease, in pregnancy, and various emerging cardiovascular diseases, cardiomyopathies, and surveys of rheumatic heart disease that they have done under the CREST program. And various mental health issues, depression, schizophrenia, alcohol, substance abuse, organic mental disorders, childhood mental disorders, and so on. These are, again, extremely important areas in mental health. Women's health. Now, women's health is often cross-cutting. Maternal mortality and morbidity, cervical cancer, gender-based violence, adolescent sexual reproductive health, family planning, sexually transmitted infections, cardiac diseases in pregnancy, perinatal mortality, and morbidity. And in pulmonary diseases, these are just indicative diseases. There are many other lung diseases that we shall hope people will tackle. Chronic obstructive pulmonary disease, asthma, and hematological disorders, sickle cell disease, aplastic anemia, and thrombophilia. And dental and craniofacial, various abnormalities of the face, cancers that affect the mouth and face, Kaposi's sarcoma, and other conditions, including determinants of oral health. You know, determinants of oral health in the country, poor oral health-seeking behavior. You know, you may ask yourself, when was the last time you saw your dentist? And you don't tell me that you saw him in his office. To implement such a program, which is not only labor-intensive, but also very demanding academically, and we may not have all the expertise locally, we depend on our partners. We have both external and in-country partners. University of Colorado, Denver, with whom we have had more than 15 years collaboration. Stanford University, also another long-term collaborator. University College London, long-term collaborator. King's College London, and University of Cape Town. And in-country, UZ-UCSF, Professor Chireje is somewhere here, UZ-CRC, BRTI, IBST, there is Professor Nasim Rengwa, Cheshire, Professor Cowan is somewhere here, SACO, well, same Professor Matenga, and Professor Rati, over there. I think Professor Gomo is not around. And then we have ETRAP, NORAD, and Zichiri. I don't know if Professor Chinanga is somewhere here. So these are very important collaborators because we intend to embed, to place some of our trainees in their institutes to get practical experience. This is just an organizational structure, and we have training advisory committee, very important. And particularly in this application, we were requested to choose very carefully. And we think we chose a very powerful group. There's Professor Chizonga, there's Professor Aiden Young, I think she must have told him. I think I saw her there. Then there is Professor Colin Masim Rengwa, is somewhere here. Yeah. And then Professor Michelle Barry from Stanford, Professor Ndungu, who is at UKZN, and Professor Colbert, who is in Malawi, and she is with the London School of Tropical Medicine and Hygiene. The steering committee is composed of Professor Matenge, Chipato, Chingono, Bizo, and Magwali, the same group that put together the application. I think I did mention Professor Nachi, who is seated next to Mr. Chingono. And we reached out to a number of people to act as mentors, and 26 people agreed, both locally and in our partner institutions, and they will be able to mentor our trainees. So these are really this is the leadership of the program itself, but very important. We had a very strong administrative unit when we ran MEPI, CRIS, and NINCAS. And we realized how important that was. These are non-academic, but without them ensuring that the program is well monitored, the program is well executed, you'll have problems. So we transitioned nearly all of them to work in Perfect, and we're extremely grateful for their hard work. And these are really the various positions. And this is a group that is very comfortable with us. They've been with us for the last 5 years. Where are we going to get the trainees from? Fortunately, there have been many programs that have produced raw material for us. That's the pipeline. So SACO, Fogati, MEPI, Ikohota, AIDS and TB, and there are other programs. You know, the usual MSc, MNed, and PhD programs. That will give us the pool of potential trainees. And this is just to show you some of the trainees who went through the MEPI program, well, except Professor Matenga, and then some more. And you can see the dean is handing out a computer to some of the trainees. So the figure here probably varies a little bit because I stopped counting at 2014. Professor Matenga has shown you that this is now gone to over 80 and this is gone to over more than 10. So these are MEPI scholars who also form the substrate for us to choose from for this program. Requirements. Eligibility, as I say, all UZ College of Health Science departments are eligible. Probably I should have said the entire university really, as long as you are a current faculty member. And the qualifications, MEd or equivalent, MSc, MPhil or PhD. We felt compelled to put an age restriction because we really want to get maximum intellectual benefit from you. So if we had extended the age a little further, we may not have as much time. And and we really expect people to be committed to a research career. Otherwise, you'll be wasting your time and our time. And commitment to complete all components of the program, commitment to remain on faculty. We don't want you to train you for the world, even if the money was coming from somewhere else. We want to train you for our college. And we expect departmental chairs, departmental boards to really help us and they should really endorse those who we choose. So the training program itself, we've got a flyer which details this out, so I will not go through it in great detail. But there are core research skills, like research methodology, health information literacy, and so on. And then we have associated skills and training. And I was talking to the Vice Chancellor. He really feels these are exceedingly important. It should not just be things that we train the perfect trainees, but everybody should acquire that, and the whole university should really be exposed to leadership, bioinformatics, biosafety, intellectual property rights, and technology transfer. And practical training. Mentorship is critical. Mentored research projects are extremely important, and trainees will have chances of going for electives, within or without, and various attachments. What can trainees expect? Support for any courses and fees which are required if the course is not provided in-house, funding for the mentored project, and any training-related travel. And we expect that the departments will give them protected time, and there may be other requirements that are important for each individual trainee. So the departments have a lot of say, have a lot of sway in this training. We really expect that trainees will spend something of the order of 20 hours per week. And Professor Matenga will tell you that's nothing. He spends even a lot more. He spent a lot more when putting together the perfect application. To be devoted to research activities, the department should encourage potential junior academics to apply. They know their, registrars, they know their postgraduates best, so they should push them to put an application forward, and they should support the trainees during the program itself. Now, this is a compressed cartoon of the training program itself. So, I've already mentioned these various courses, but underpinning all this is mentorship. It's critical from day one up to the last day, 24 months. We expect mentorship to be taking place. So we want to take full advantage of role models within the college and not let them retire without leaving behind their experience and expertise. Presentation skills. I think it's extremely critical that people should be able to present their knowledge. So presentation skills, we think, should be acquired from day one, or should be practiced at home from day one. And all the other aspects of the training will take place at various times during the training program itself. Now, this is also a cartoon just to show you, the timelines for training. So, the first cohort we hope will get on board in May, and 24 months later, in May 2016, and in May 2018, that will be completion of training for cohort 1, and we expect to take on board 10 trainees. Cohort 2 will be the following year, again from May 2017 up to April 2019, and the last cohort from May 2018 up to April 2020. So that was really a quick preview, but I think it's really enough for chairs of departments, for faculty board members, for scholars, and all those who are interested in the program to get a sense of what this involves. So let me once again really thank the Vice Chancellor for his great support. And Professor Matenga really stressed that during MEPI, whenever we had big symposia with all the other medical schools, it was always pointed out that we had exceptional support within our own university. Similarly, the Dean and the Dean often traveled with me for MEPI council meetings, and his contribution has always been highly valued and respected. The CEO of Parinato Hospital, as I told you, he is our host, and he has done so most generously. And of course, my colleagues and faculty, the non-academics, they play an extremely critical role, and mentors and advisors. And of course, our collaborators, both external and internal. And this is again just logos from our various collaborators, and I thank you.
Thank you, Professor Akim, for the overview of the PEPFACTIC grant. And I think we came to learn that cartoons come in different forms. Right, ladies and gentlemen, at this point in time, let me call upon the Vice Chancellor, University of Zimbabwe, Professor Nyagura, to deliver his speech, being or marking the official launch of the PEPFACT program.
Good evening. I'm sure there are people. Good evening. Well, thank you very much, Director of Ceremonies, the Acting Permanent Secretary, the Minister of Health and Child Welfare, Mr. Magwanya, the Dean of the College, Professor Chitonga, the Group Chief Executive, Parinato Hospital, Mr. Sigora, colleagues from partner institutions, colleagues from UZ, senior management from the University of Zimbabwe, invited guests, ladies and gentlemen. My task has been made very simple because a lot of information has been given about PEPFACT. So I don't need to repeat, that. So I've decided not to read, the speech that was prepared. I might say a few things, from deep down, my heart. about what I think about the College of Health Sciences. I think I need to begin by recognizing the excellent work that the College of Health Sciences is doing. I must also indicate that the things that you have achieved reflect very serious strategic thinking, strategic planning, strategic execution, of the business for you to be able to achieve the results that were presented, here. You also did well by showcasing some of your products, at least two. That is very important, where you are trying to convince people to support you, to give you money, to share in the vision, that you have. And so it gave me, lots of insights into what really goes on in the training process, the kinds of skills that the trainees acquire, as they're being guided, by colleagues, in the College of Health Sciences. So I think, for that we need to highly commend you for the good work, that you are doing. Now, obviously, the successes that you have witnessed could not be possible without, good working relations with, the hospitals that we use. We don't have a UZ teaching hospital, although we are thinking about putting up one, which in our view would become the referral hospital for the country, where we will have all the expertise to cover the different areas that were presented, here. I think, that is going to be good for the country. And now I'm much more convinced that we are now ready for having a teaching hospital from the work that I've seen. So that becomes a challenge, that we have to deal with in central administration, to see how best we can, put up a teaching hospital. We know there are many other universities, for example, Kenyatta University, who are just going to commission a beautiful, Kenyatta University Teaching Hospital on the 15th of March this year. And so it can be done, and I think we have the determination, to do it. The colleagues from partner universities are extremely important because we are now living in a global village. There are no boundaries to knowledge and information. You can access information even while you're seated here, because we've been told there is now Wi-Fi connectivity everywhere, at Parrenyatwa here, certainly in the side of the Parrenyatwa hospital we are using, and the University of Zimbabwe. So it means you can communicate with your counterparts, elsewhere, whether they're in the USA, in the UK, whether they're even closer in South Africa, or in Kenya, Uganda, Ethiopia, West Africa, etc. Because of that, it means we need to pay more attention in developing IT resources, and in particular IT infrastructure, so that you have the capability of doing teleconferencing with your colleagues, wherever they are. And that would also add value to the training of your students, because you could have a recognized expert somewhere in the world delivering a lecture from, thousands of kilometers away, and still interacting, in real time with, the students. And that, I think, is the next kind of development that we want to enhance whatever is there now, for us to be able to be active participants in the global village of learners, or, of scholars, or of researchers. And so That is something that we need to do and something we must seriously consider for the College of Health Sciences. I must admit, that I've always admired the research training courses that are offered by the college. They have become the benchmark for the rest of the university, and I've made this very clear to the dean and other colleagues. And I wish you could continue, being leaders, in this area and set, the best practices in the training of future researchers, for the college, for the institution, for the country, for the continent, and, and beyond. And so there are a number of things that I have, noted throughout, my tenure as VC, where the college has excelled and where the college has provided leadership. And it is this aspect of leadership that you need to capitalize on so that we are able to document best practices for future, scholars, future researchers, future professors, and, future students who will come after you. The recognition of Professor Kim was quite a thrilling thing, for me. Despite the economic, strangled environment in which we are operating, we are still able to do wonderful things. And here is a recognition of these wonderful things we are able to do. The recognition of Professor Kim through the award of the Honorable Doctor of Science, degree. That is a magnificent, achievement. And it says a lot, not just about the College of Health Sciences, but about the University of Zimbabwe. And I think I was absolutely, thrilled, by it. And I'm hoping that we will not have outside institutions recognize our champions in academia. We need to develop this culture ourselves of recognizing our champions in the different areas across, the university. But, the University of London has done it before us. And I was saying to Professor Kim, I've come to conclude that it is an African to recognize the achievements of another African. And I think we need to change that kind of mindset, that kind of tradition. It is a retrogressive, tradition. I think we need to be able to celebrate the achievements of one of us within the university community. And so all of us have to be, part of the critical mass to change the mindset of taking things for granted when achievements, are done by colleagues within the university community. And the building in which we are is another example of a major milestone by the College of Health Sciences. And so it's not that, the donors had nowhere to put the money. They believed in what you demonstrated. They were convinced that you meant what you had presented in your, proposals. And they were also convinced that you were serious actors in terms of what you had promised you wanted to undertake. And that should be, an aspect or an attribute that should be developed, in the college. It should spread across, every individual in the College of Health Sciences. Imagine if we had more teams, so dynamic, so vibrant, so serious, like the team, led by Professor Kim, we would be celebrating almost every week, isn't it? And that is what I expect, to see. To see the younger academics emulating what, the old, academics are doing. Remember, we don't compete with each other. We only complement each other. We are working for the same goal, to produce quality human resources for Zimbabwe, the region, the continent, and beyond. And so there is no question of competition. There is only the question of complementing what we are doing. And I can assure you, if we take this approach, our results are going to have even greater impact than what has been presented here. We will be talking of the benefits that are being realized in Ethiopia, in Senegal, in Nigeria, in Ghana, while, things are happening here. And that, I think, should be the new spirit of working in a global community. Together, across the globe, we have the responsibility to improve the quality of life of humankind. And what you are doing here is certainly demonstrating that commitment to improving the life of humankind, not just of Zimbabwe, but of humankind. And so all I have to say is that I'm always very happy to come to the college, because I go away with new ideas. I go away much more informed about, the business that you are undertaking here. And all I can really say is I wish you to do even more. My expectation is that until we have totally transformed systems that require our services, much work is still to be done. And so we have to do that. We all know the burden, that we have in the health sector, and that should be the yardstick in terms of how much we have done, how much we still have to do. And, millions of people are looking on us and are counting on us to make things better, not just for ourselves, but for the country, for sub-Saharan Africa, for the whole continent, for the world at large. And so as you embark on this new program, Perfect, I want to wish you well, and it is only my pleasure now to officially declare the Perfect program launched. I thank you very much.
Thank you, Vice Chancellor, for the informative and encouraging speech, and for officially launching the Perfect program. Ladies and gentlemen, at this point in time, let me call Professor Chipato to give us a vote of thanks, and while we wait to go to the next stage of the program.
Thank you. Ladies and gentlemen, I have a very simple task to thank people. I know it might appear like we are thanking these people too much. It's sycophantic, but I want to do it again because I think it's heartfelt from us here in the College of Health Science. Professor Yagura, your support during MEPI, as Professor Hakim has said, is truly appreciated. During the 5 years of the MEPI program, there was a continuous monitoring and evaluation by external people to see how we are doing. They always commented about the support that we had from the university hierarchy, from the Ministry of Higher Education, and from the Ministry of Health. So I want to thank you and the representatives from the ministry and the Dean for being so supportive for both MEPI as well as Perfect. Let it continue. Mr. Zgora, when we come to you looking for premises and beds to do our research, I hope you will appreciate that we are doing this in the interest of the whole institution, in the interest of the whole country. So I want to thank you, ladies and gentlemen, for coming in such numbers. It means that we are doing a good job and that we will continue to be supported by everyone. I'm cognizant of the short time that we have since we are behind time. There are refreshments that are placed outside. No psychoactive substances. So I don't want to stop people from having refreshments. So I thank you all for coming, finally, let me thank the Secretariat of the Perfect, the former MEPI Secretariat, for putting all this together and for all the work that they're doing in the background. Thank you very much.
Thank you, Professor Chipatu, for thanking everyone. Ladies and gentlemen, we've come to the end of our program, but like stated, we have some refreshments